Estimados amigos y colegas, miembros de la Sociedad Interamericana de Endoscopia Digestiva, es un honor estar con todos ustedes tal día como hoy para traerles el tercer webinar de nuestro ciclo científico online. Hoy tendremos a la doctora Dilhana Badurdee, profesora asistente de la División Médica de Gastroenterología de la Universidad de Hopkins. Ella nos hablará sobre el manejo endoscópico de las complicaciones de la cirugía bariátrica. Dear friends and colleagues, members of the Inter-American Society of Digestive Endoscopy, it is a honor to be with you the day of today in order to share with our audience the third webinar of our online scientific activity. Today we will have Dilhana Badurdee, she is Assistant Professor of Medicine Division of Gastroenterology, Johns Hopkins University, Baltimore, Maryland. Hello Dilhana, how are you today? Can you hear me?
Thank you, Victor. I'm good. It's a pleasure to be presenting to everyone.
Okay, you are starting now, Dilhana.
So today I'm going to present on endoscopic management of bariatric surgery complications. So I have no relevant disclosures. The things that we're going to talk about today are the indications for endoscopic management. We see a couple of things: staple line hemorrhage, recalcitrant marginal ulcers, gastrojejunal strictures after Roux-en-Y gastric bypass, functional stenosis after sleeve gastrectomy procedures, staple line leaks and fistulas, which can be quite difficult to manage, as well as GERD post-sleeve gastrectomy, and weight gain post-Roux-en-Y gastric bypass. I'm not going to talk too much about Roux-en-Y gastric bypass, weight gain post-Roux-en-Y gastric bypass, because I think everyone is quite familiar with the outlet reduction procedure, but we'll talk about the others in detail. So let's start with staple line hemorrhage. Now, generally, acute GI bleeding is more common in Roux-en-Y gastric bypass, in which it can occur in about 1 to 5% of patients after surgery. So it's more common to see staple line hemorrhage after Roux-en-Y gastric bypass than sleeve gastrectomy. And it's actually more common after a laparoscopic Roux-en-Y versus an open Roux-en-Y. The majority of the bleeding occurs in the first 3 days after surgery. And patients will present with tachycardia, a decrease in their hemoglobin, hematemesis, and melena sometimes. Now, it's important to remember that some of the bleeding can occur extraluminally. And if you suspect an extraluminal source of bleeding, then you need to do immediate imaging, usually with a CT scan, and then emergent surgical intervention is mandatory. However, if you think that the bleeding is intraluminal, then an EGD may be performed. Often these procedures have to be performed very carefully because these patients are post-procedure. You can't do too much insufflation. CO2 must be used. And you don't want to cause a staple line dehiscence, or you don't want to open up one of these staple lines because all the incisions and the sutures are fresh. Now, when we use endoscopic therapy, often we use epinephrine injection, sometimes heater probe or clipping, but you have to be very careful when you use a heater probe because if bleeding originates from the staple line, then there's a high risk for perforation when you're using a heater probe. So this is a marginal ulcer. You can see here, right here at the gastrojejunal anastomosis, this white area, as well as in this picture, this is a different view. And it's the most common cause of epigastric pain after Roux-en-Y gastric bypass, but also can be a cause of bleeding. It occurs in about 16% of patients, and it can present from weeks to months after surgery. But most cases develop in the first 2 months after surgery. Now, the risk factors for marginal ulcers are multiple. The procedure itself, so if you have a big pouch or if you have some staple line dehiscence, or even if there's tension at the gastrojejunal anastomosis, this can predispose to a marginal ulcer. But more than that, the major factors are long-term use of NSAIDs, so Motrin, naproxen, this kind of medication, Helicobacter pylori infection, which is why now we either do an endoscopy or we do an H. pylori breath or stool test to eradicate H. pylori prior to the patient going to surgery. If the patient is a smoker or the patient drinks alcohol, and of course diabetes, because patients who have diabetes or smoke tobacco, they have microvessel disease, which not only causes these ulcers but also prevents healing. So one of the things you have to do is test for H. pylori in these patients and then eradicate if it is positive. If the patient is using NSAIDs for pain, then this should be removed. And then you have to start the patient on proton pump inhibitors or carafate or sucralfate, which will coat the lining of not just the stomach pouch, but also the jejunum, and it will promote healing. Now, one thing to remember is that when you're using, I'm going to go back to that slide. One thing to remember is that when you're using proton pump inhibitors, and I have a slide on this later on, you have to open the capsule because you want the proton pump inhibitor to work in the gastric pouch. And often medications are delayed release or they're designed to stay in the stomach for a long duration. And in these Roux-en-Y gastric bypass patients, the proton pump inhibitor will go right through into the jejunum. So by using either a liquid formulation or opening the capsule, and we have the patient open it into some applesauce or some pudding and consume it so that it works mostly in the pouch and at the gastrojejunal anastomosis. So again, larger pouches predispose as well as gastrogastric fistulas, diabetes, tobacco, NSAIDs, H. pylori, and of course foreign material. So if there's a surgical suture remaining, then that needs to be removed. I'm not sure if this picture is projecting very well, but you can see right here there's staples from the anastomosis, and this is actually what's causing the ulcer. So those staples need to be removed. Now, we can use endoscopic suturing for massively bleeding marginal ulcers. And this can be used even up to 10 days post Roux-en-Y gastric bypass. And this is a video I'm going to show you from our institute, and this was written up as a video submission. So you can see here, I'm just going to play this for you. And you can see here there's a huge blood clot in the stomach.
In the gastric pouch with the evidence of recent but not active bleeding.
So you can see that the blood clot is being removed using a Rothnet. And then you'll be able to see the ulcer.
Removed, the culprit ulcer was identified and the large visible vessel on the right.
So you can see the ulcer right here, and there's actually a big visible vessel.
Approximately 6 mm and it's pulsating. The decision was made to perform dual therapy to this ulcer. So initially, epinephrine is injected into 4 quadrants surrounding the edge of ulcer. Unfortunately, this triggered bleeding, which pertained significantly. Electrocautery was thought unlikely to benefit, and the decision was made to suture the ulcer endoscopically. Suturing is commenced from the area of bleeding from right-hand side of the ulcer. The decision was to do running suture pattern starting from the right-hand side and then moving to left. So starting from bottom to top, sutures were performed. The suture apparatus uses 2 non-observable rolling sutures, and full thickness bites are taken, and now you can see 4th full thickness bite being taken. The 5th bite is now performed on the lower edge of the ulcer, and then after that 6th bite is taken, and then T-tag is dropped, and the suture is cinched. Now you can see the bleeding has stopped, so adequate tamponade has been achieved by oversealing of the ulcer. The cinch can be seen deployed here. Follow-up endoscopy was performed as a routine outpatient procedure to confirm the ulcer had healed. You can see complete resolution of both the ulcers, and there is some surgical suture material and 1 cinch remaining.
So you can see that even early on, for the management of bleeding ulcers, endoscopic suturing can be used. Now, this is another video I'm going to show you, and here, this was a study again from our institute for the endoscopic management of recalcitrant marginal ulcers. And we actually had several patients present in this fashion. And the way we defined a recalcitrant marginal ulcer was that it was an ulcer that persisted for up to 6 to 8 weeks despite maximal medical therapy. And when we say maximal medical therapy, we're talking about 40 milligrams of a PPI twice a day, as well as sucralfate 4 times a day. And the PPI, as I said before, needs to be an opened capsule or a liquid formulation. And of course, removal of all inflicting factors such as cessation of smoking, H. pylori eradication, as well as removal of NSAIDs. So I'm going to show you this video here. And again, you can see that there's successful management with endoscopic suturing. So here you can see this big ulcer. And we're going to oversaw this ulcer in order to get it to heal. So you can see here several full thickness sutures have been taken, and now we're deploying the cinch. And you can see the T-tag over there as well, and you can see the ulcer is gone now. This is the follow-up EGD, and you can see that the previous ulcer that was right here in this location has now disappeared. So successful use of endoscopic suturing, both for bleeding ulcers as well as non-healing ulcers. Now, this is, I would consider, a landmark paper by Alison Schulman and Chris Thompson. And what they showed is that the open PPI reduces the time to healing in these patients with gastric ulcers post-Roux-en-Y gastric bypass. And you can see here, this is the time to healing, the number of days. And this is the open capsule, and this is the closed capsule. So the closed capsule, it takes much longer for healing. So if you have any patients with a non-healing Roux-en-Y gastric bypass, marginal ulcers, try using the open capsule twice a day, and that should improve healing. So moving on, we're going to talk about strictures post-sleeve gastrectomy. And this can often be identified on endoscopy, but even better on fluoroscopy, or if you have, the patient have an upper GI and a barium. And you can see here in this second picture that there is a relative narrowing right here, but also a tortuosity. You see how the sleeve is sort of rotating inwards right here. And on this picture, again, you see that there's a narrowing right here. You can see here, this is the stapled edge, and you can see that there's a relative narrowing here. But again, you can appreciate that the sleeve is not straight, that there is a slight curve right here. And these strictures, and because of these strictures, patients can present, with nausea, with vomiting, and sometimes with reflux. So what we do for these patients is that we dilate the sleeve. And I'm going to play this video for you here of a balloon dilation, which you can see we're introducing the endoscope now. And you can see here again, there is this tortuosity right here with a narrowing. And we're going to go all the way into the duodenum. And now we are going to pass the catheter so that we can pass the balloon over it. And then right at the gastric stenosis, you're going to introduce the balloon and you're going to dilate. And you can hold the dilation anywhere from 1 to 3 minutes. So you have to watch carefully to make sure you don't perforate. If the balloon is too close to the pylorus, then the risk of perforation increases. And these strictures are often at the incisura. That is where you often see this narrowing or this tortuosity. So you want to look carefully through the balloon so you can look at the tissue as well as the muscle and just make sure that you aren't causing a perforation. You will see some bleeding and you can see a blanching of the tissue, but you shouldn't see opening of the tissue so that the muscle layer is visible. Then you've dilated too much. And now you're going to see the view post-dilation. You can see reinspection after dilation. You can see that it's opened up significantly in this picture. Right, so moving along, this is a paper again that was presented from our institute, and it's basically an algorithmic approach to the management of these patients with stenosis. What we recommend initially to start off with is a barium swallow and an EGD. And if the patient has a gastric stenosis, then we start by dilation with a 30 millimeter achalasia balloon. If the stricture is persistent, then you repeat dilation, but at that same 35 millimeter balloon, and you can repeat dilations up to 3 to 4 times every 6 to 8 weeks. And if the dilation is persistent, then we recommend a fully covered self-expanding metal stent. And these stents need to be sutured in place, and they have to be changed every 6 months. And if the stricture persists, then the patient will end up needing surgery, either a Roux-en-Y gastric bypass or a seromyotomy. So again, here you can see the suture line over here, and you can see that it's not a straight line. And again, you can see the balloon dilation, and you can see that there is rupture of the muscle right there. This is the gastrogram, and you can see right here that there is a narrowing. All right, so this is a deployment of a stent. And you can see here, this is the picture before the stent is placed. So it's a fairly severe and a fairly long stricture. So we deployed a fully covered self-expanding metal stent, and you can see here how the stent appears. This is where the narrowing is, and you can see it hasn't completely opened up. And now the stent is being secured with a couple of sutures, and this is the gastrogram with the stent present, and you can see that that stricture has now opened up significantly. So what are the risk factors for post-bariatric surgery leaks? A high BMI, diabetes, sleep apnea, hypertension, age more than 55. It's more common in males as well as patients who've had previous surgery. The most common sites for a Roux-en-Y gastric bypass leak are here at the angle of His, but you also can see leaks at other sites, so the gastrojejunal anastomosis. Sometimes we see leaks in the remnant stomach, also at the jejunal anastomosis, and rarely in the blind loop. In the sleeve gastrectomy patients, the most common site of the bleeding is up here at the angle of His, and this is because this is the area of relative high pressure, and that's the reason we see bleeding at that site. Now, the things that we used to take into consideration are the hemodynamic stability of the patient, as well as the time from surgery. And this is how the patients were managed in the past. But now we like to take into consideration other things. So some of the things that we want to consider is, one, the size of the leak, but also what we call the grade of stenosis and the presence of a stricture. And these strictures are the same strictures that I showed you in those previous pictures. So if you have a high-grade stenosis where the leak is a fairly big leak, then often these patients will also have a stricture, and that stricture needs to be dilated in order to promote healing. So this is an algorithm that we published, and this takes into consideration the size of the leak, the time from surgery, high versus low-grade stenosis, and based on this, we present a sort of algorithmic approach to managing these patients. So if the patient presents early, that is less than 6 weeks, often it is easy to manage these patients. And if the size of the leak is small, so less than 5 millimeters. As the size of the leak is bigger, so more than 10 millimeters, or if the patient has had this leak in place for more than 6 weeks, then it becomes quite difficult to manage these patients. And often these patients with high-grade leaks that have been there for more than 6 weeks, they will need endoscopic maneuvers. So the things that we use are endoscopic vacuum therapy as well as endoscopic internal drainage. Now, one of the other things that we use to decide if this is a low-grade versus a high-grade leak is that we inject contrast. And we inject contrast usually right at the GE junction. And we look to see how much of the contrast is going into the antrum versus how much of the contrast is actually going into the leak itself. And if the antrum fills before the leak, then we know it's a low-grade stenosis. But if the leak fills before the antrum, then we consider that a high-grade stenosis. So I'm going to show you some pictures now. So you can see here, this is the gastric leak. And in this patient, it was a small leak. And because of that, that presented early, and because of that, we decided to manage this patient with primary closure. Now, with primary closure, here we're using argon plasma coagulation. And then we sutured the leak with endoscopic suturing. And here, initially, you can see that the leak is present, and now you can see that the majority of the leak has been closed. So if it is an early presentation, if it is a small leak, and if it's what we call a low-grade stenosis, so you can see here the antrum is filling much before the leak is filling. So if it's a low-grade stenosis, then these patients can be managed with primary closure. Now, now in this patient, you can see here we are managing this patient with a stent, and these stents are used as what we call diversion therapy. Now, the diversion therapy is useful because, one, it not only provides enteral nutrition for these patients, but it also provides sort of closure of the leak. So often these patients will need an external drain that you can see in this picture. So you can see here the patient has an external drain. But the good thing is that these patients don't have to be admitted to the hospital, and they don't have to go on TPN, which can absolutely increase their risk of other complications. So you're draining externally, so there's percutaneous drainage. The stent is not only opening up, if there is a stricture, it's opening up that stricture, but it's also allowing you to feed the patient enterally. And sometimes you have to put in a NJ tube if the patient can't tolerate, but at least the patient doesn't have to stay in the hospital for TPN. Now, some of the newer things that we are doing, this is called a septotomy, and this is actually very interesting. You can see here that there's this cavity here with a fairly big leak. And we do this usually when it's a high-grade leak. So you can see here how the cavity is filling fairly quickly, and there's not much contrast going into the antrum. So this is a high-grade leak, and you can see here on the endoscopic picture that this leak has probably been there for quite a while. So now what we're trying to do is basically equalize the pressure between that leak cavity as well as the lumen of your stomach. So the idea is to equalize the pressure so that the gastric content is not primarily going into the leak area, instead it stays in the whole area as a leak cavity. So here you can see the leak cavity, you can see the staples here. And what we do is basically identify this pseudoseptum in between the leak cavity and the actual gastric remnant, or the stomach sleeve. So here you can see, using either a needle knife or APC, we are basically making an incision in this pseudoseptum. And by doing that, we are basically opening up that cavity directly into the stomach, or directly into the gastric sleeve. So we equalize the pressure, and you can see here now. You can see the gastric leak. It's coated in this white sort of exudate, and this is, post-septotomy. And now you can compare this fluoroscopic image with this fluoroscopic image, and you can see that it's all one cavity now, whereas here you had two separate cavities. And this has worked, there are a lot of folks who've had significant success with this. Now, one of the other things that we do is something called endoscopic vacuum therapy. There are quite a few people who have presented papers on endoscopic vacuum therapy. We don't do it a lot here at Hopkins, and because of that, I don't have a paper or a video to show you, but I think it's actually done quite a bit in South America as well as certain areas in Brazil. And what they do is basically there are commercially available vacuum, vacuums, but there's also things that you can make locally by wrapping gauze around either an NG tube or just a suction tubing, and then you connect that to negative pressure. The only caveat with that is that the patient will need multiple endoscopies to change the sponge out every 3 to 5 days. And you have to either do enteral nutrition or you have to have a jejunal tube for feeding. And the patient most likely will have to stay in the hospital based on the situation so that they can have these frequent endoscopies. But there are a lot of studies where they've had good success managing these patients with endoscopic vacuum therapy. All right, so moving on, we're going to talk about reflux post-sleeve gastrectomy. And I'm not sure how common it is in South America, but we actually see this quite a bit in the United States. So the incidence of GERD after an LSG can be as high as 35%. And it can be really quite troublesome for these patients. And again, there's no algorithmic approach or there's no guidelines on how to manage these patients. What we recommend initially, and there's a paper on this. What we recommend initially is to optimize the bariatric surgery outcomes. We recommend a foregut evaluation. So any patient who's presenting for bariatric surgery, one of the things that you have to discuss with them is, do they have GERD prior to their procedure? And if they do have GERD, then they should probably be worked up further. So based on this paper, what they recommend is an EGD and an esophagogram. And if the patient actually desires a sleeve, then you're going to do further testing with either esophageal pH testing or a Bravo and high-resolution manometry. And based on this study, Barrett's esophagus was seen in 4% of patients, grade C or D esophagitis was seen in about 18% of patients, a hiatal hernia in 36% of patients, and abnormal esophageal motility in 41%. And 83% of these patients actually had an abnormal Demeester score. So if there's anything abnormal, then you're going to recommend a Roux-en-Y gastric bypass versus recommending a sleeve. And that can reduce the risk of these complications post-surgery. So now I would like to talk to you about a very novel procedure. It's called a RAP. It's a resection and plication procedure. This is the pilot study done by Petros Benias. And I'm going to show you his video. This is not a Hopkins video. This is from Dr. Petros. And here he does what they call a resection and plication, which is really quite interesting. So you can see here in retroflexion, and then in forward view, the patient has some esophagitis as well as a small hernia. And what they're doing is basically a mucosectomy using a band EMR device. And basically, they're resecting all around the GE junction. So full thickness resection using this very novel sort of procedure. And you can see here as they progress around the GE junction. And they do this in a specific pattern, and I'm going to show you a picture in just a second. Now in retroflexion, they're completing the mucosal resection with a snare, and you can see here, so very nicely done. And then what they do is they use endoscopic suturing, but in a specific pattern. And then they pull down on those sutures in order to tighten or basically create a lower esophageal sphincter in these patients. So this is, a simple procedure using technology that is already in existence. and it's not something that has to be learned. Most therapeutic endoscopists know how to do endoscopic submucosal dissection as well as suturing. So something that can be done by most therapeutic endoscopists or bariatric endoscopists. And now they're deploying the cinch, and you can see in retroflexion there is sort of a nice tight wrap around the endoscope. So, a successful procedure. And in this picture, you can see here, this is the pattern that they use for the suturing. And this is pre-procedure, this is post-procedure. So really quite a nice effect. They present the data from 10 of their subjects, and you can see the duration of follow-up up to 24 months. And most of these patients had a very good reduction in their GERD quality of life scores. Now, this is another paper, not from my institute. This is from Chris Thompson. And again, he presents this video of a similar procedure in a sleeve gastrectomy patient, but here they are they only do the mucosectomy around 85% of the circumference. So this 15% of the circumference remains, and they only do the mucosectomy around the remaining 85%. And the reason that they leave this portion is because they don't want to cause a stricture. Now, unlike Dr. Benias's video, in this video you're going to see there's no endoscopic suturing. This is merely an anti-reflux mucosectomy. So I'm going to play this video for you. And again, this is really quite interesting. It's available on Video GIE if you want to see it in detail. But basically, I'm just going to present the video portion of it for you. So here they use APC to mark the 85% or the 15% area that they are not going to do the mucosectomy on. And like I said, this is to prevent stricture formation. And unlike in the previous video, here with the mucosectomy, they're actually doing submucosal lifting. And they use a solution of methylene blue, epinephrine, and normal saline.
Diagnostic EGD was performed first, notable only for mild irregularity of the Z-line.
And you can see here, this is in retroflexion. They're just looking at how severe the patient's hiatal hernia is, to see if the patient has any reflux. And now you can see they're injecting this solution. First, they are marking the area that they're not going to target using APC. So that's the area that they're going to leave behind, and they're not going to do a mucosectomy on this area. So that's 15% of the circumference. So slight difference in the two procedures, but basically a similar thought process in recreating a new lower esophageal sphincter. So here initially they use a cap, so they're injecting. You can see that they're creating a lift here.
Endoscopic mucosal resection is performed. In the initial EMR, we use the band EMR device, as seen here. Finally, a snare is positioned below the level of the band and is used to resect the mucosa. The same steps are repeated for the second resection. The area immediately adjacent to the prior resection site is targeted. In this case, the second EMR was also performed band EMR device and ultimately was removed with the snare. We were concerned that we included a portion of the prior resection site as seen on the left portion of the banded tissue, and we thus opted to perform the resection over the band. Here, we see the retroflex and forward-facing view after our initial two resections. Now, for the third and all subsequent resections, the band EMR kit was replaced with a CAT EMR kit. The tissue is still injected in order to lift the mucosa from the muscularis propria. However, in this scenario, the snare is fitted around the mucosa while it is suctioned into the CAT device. Once the snare is firmly in place, the suction is released and the mucosa is able to be resected. The same procedure is performed for the fourth resection, and shown here is the result in forward view after our first 4 resections. There are several reasons why we switched from the band to the CAP EMR kit. The band EMR kit allowed for a smaller amount of mucosa to be resected, and thus was more time-consuming, leading to a longer procedure time, and it proved difficult to maneuver the injection needle and the snare through the banding cap. When performed without the band EMR kit, we were able to resect larger pieces at a time, thus reducing procedure time, and it was much easier to maneuver the snare into position for the resection. This and prior arms procedures have been performed with a resection rather than a band and slough technique. Theoretically, the use of the band and slough technique may have a lower bleeding risk. However, it may not provide the same clinical results due to unclear impact of mucosal bridges between the bands. The ninth resection was performed in similar fashion. The tissue was then re-examined in the retroflex view, and finally, the location of the last resection is found. Notably, in this scenario, given the difficulty of maneuvering the scope into position, the snare has already been opened and fitted around the cap. Thus, once the mucosa is suctioned into the cap, the snare is already in position to be closed around the mucosa, as seen here. As the last step, prophylactic hemostasis of the vessels in the muscularis propria layer was performed using a coagulation grasper. Shown here is the final outcome in the retroflex view. As noted here, we have avoided the 15% of the circumferential area that was initially marked in the beginning of the case. Her GERD symptoms were significantly improved following the procedure. Her GERD Q score at 3 months was 8 and showed specific improvement in sensation of heartburn, regurgitation, and need for over-the-counter medication. Repeat 24-hour pH and impedance testing at 7 months showed no increase in acid reflux or non-acid reflux, a normal Demeter score of 5.8, and no correlation with rare regurgitation and reflux. In conclusion, ARMS can provide a safe and effective means for symptomatic acid reflux control for patients with a prior sleeve gastrectomy and medically refractory GERD whom are not candidates for conversion to Roux-en-Y gastric bypass.
All right, so I'm going to end here, and if there are any questions, I'm happy to answer questions now. Does anyone have any questions? Okay. Any questions? So alternatives to medications for chronic recurrent ulcers. So the main thing that we try for what we call recalcitrant ulcers that are not healing is the oversewing method. And we've had a fair degree of success, not just for post-Roux-en-Y gastric bypass ulcers, but we've had some of our therapeutic endoscopists use it even for other types of ulcers that are non-healing. And it seems like, these patients do quite well. It might be because that previously exposed area is now completely closed and not exposed to the acid anymore. Does that answer the question? Surgical alternatives. So we try to manage our patients endoscopically if possible, but you're absolutely right. If you can't get the ulcer to heal, then you have to take the patient to surgery. Do you have experience with good surgical procedures for management of these ulcers? Yeah, Victor, have you had good experience with surgery for managing chronic ulcers? Do you feel like it's a better alternative to endoscopic suturing? Okay. So, I mean, I'm not a bariatric surgeon, so I can't speak for the surgeons, but in general, with these post-bariatric surgery patients, the majority of our surgeons, they like to give us a chance to manage these patients endoscopically. They are not excited to take them back to the OR. Let me put it that way. Okay, how do you provide open PPI capsules? So you have to get, so here the only one that comes as a capsule is omeprazole. Everything else comes as a tablet. So if it's a tablet, it can't be crushed and that cannot be opened. So it has to be a capsule. You get it like the antibiotics where you can pull it apart and there are little granules on the inside. So you open that, you tell the patient to open that capsule, put it into some applesauce is what we use here, but you can use anything that has similar consistency, yogurt or some pudding or something like that, and you have the patient eat it with some other food, basically. Does that make sense? Leaks post-sleeve, percentage of success with endoscopic approach during the acute period and the chronic period. So we have more success in the acute period for sure. But like I said, it depends on the grade of the stenosis. If it's a high grade or the grade of the leak, if it's a high grade leak, unless you dilate the downstream stenosis, you're not going to have any success. But we have the best success with early leaks. So patients who present early, either acute or in the early stage in less than 6 weeks, where the grade of the leak is low and where the leak is small, so less than 5 millimeters. So those patients, you have more than 90% success. The patients where you have very little success, maybe less than 10% success, are the patients who present late, so those chronic patients who've had these fistulas or drains for a long time, where there's a high-grade leak where the cavity is really quite big and it's high-grade. So when you inject contrast, the contrast is all going into the cavity versus going into the antrum. And those are the patients that are very difficult to manage. And those are the patients that you have to try either a septotomy, endoscopic vacuum therapy, or these patients often need to be taken back to the OR. So we can certainly try endoscopic management, but leaks are difficult to manage in some cases. And if you are not having success over time, and it seems like the leak is closing, but then it opens back up, then these are the patients who need to go back to surgery. After septotomy, so often you need multiple procedures. So every 4 to 6 weeks, you're going to bring the patient back sooner if the patient becomes more symptomatic. And then you have to often increase that incision. You can't incise too much at once. So sometimes you have to incise a little bit at a time. So you do a small incision, you inject contrast, you look to see how it looks, then you allow it to heal because you don't want to cause a perforation and create more trouble. So sometimes you have to bring them back for multiple procedures. Anywhere between 4 to 6 weeks is what I would say. And then you look at the cavity again, you look at that pseudoseptum, and if you feel like there's still some room to make an incision, then you either burn the area with APC or with a needle knife and you open it up a little more until it's all one big cavity. So the good thing about the septotomy is that now everything is one big cavity. So even if it is food or liquids, yes, it can go into the into that cavity, but it can also easily drain back out into the stomach. How many patients in your experience have gone to surgery after septotomy? So sometimes we have complex patients that do need surgery. I mean, I wouldn't be able to tell you a percentage or a number, But for example, a couple of months ago, we had a very sick patient who actually her surgery, and most of these patients who are sent to us are patients who are referred to us from outside institutes. So sometimes they come from 1 or 2 hours away, and they come because not all programs have a bariatric endoscopy. So we have a lot of referrals, and this was a patient who came from an outside institute, but it had chronic had a chronic leak spanning back several years, and the patient actually developed the fistula went up into her lungs. So she developed not just a pleurocutaneous fistula, but a gastropleural fistula. And now with the negative pressure, there's absolutely nothing that can be done endoscopically. So patients like that absolutely have to go to surgery. So we do have some patients who end up going to surgery. Have gone to surgery after septotomy. I don't think we've had to send anyone to surgery after a septotomy. But I would need to talk to Dr. Kumbari, who is the director of our bariatric surgery program, and he has a lot more experience managing these patients than I have. And I'm sure that he would be able to tell us what number of patients, but I think he has pretty good success with septotomy. So the only endoscopic procedure that we do post Roux-en-Y for weight loss is outlet reduction. If the insurance will cover endoscopic suturing, then that is what we do. But we also have good success just with APC. The only unfortunate thing with APC is that sometimes you have to bring back the patient several times to make the outlet smaller. But we do both. The preferred method is endoscopic suturing. And then we also often start these patients on medications. So once they reach a plateau, so they may lose 30, 40, 50 pounds, depending on how much they lose after the outlet reduction, then often we'll add medications. So I don't think we have enough data to see if the redundant fundus is a cause for the reflux. You're absolutely right. We often see that little, what we call a dog ear with acid pooling. And with the mucosectomy procedure, the one that Chris Thompson presents in his video, you're right. We're not addressing the redundant fundus. But with the endoscopic suturing, I suppose it is possible to shorten up or make the fundus smaller if you so choose to do that. But these are studies in the very early stage, pilot studies. So I think we're going to see lots of data coming out on management of reflux after sleeves, because it is a big problem. And we've had patients go to surgery. They have a Roux-en-Y gastric bypass because of severe esophagitis, Barrett's after many years, or just severe symptoms. So we've sent patients to surgery. Okay.
Hello, Dilhana, Bracho, can you hear me? Okay, so thank you very much, Dilhana. It was a superb presentation. Thank you for joining us at the Inter-American Society for Dissective. So amazing that we can be all together all around the Americas and bringing all this information and wisdom that make us, so strong in how we deal with our patients and with all the information that is all around us. So, being so close despite the distance is amazing. So thank you very much. Thank you very much, Dr. Bracho and all the team in Venezuela that make this possible. And thank you all that they are joining us around the three Americas. Thank you very much. It was a pleasure.
Thank you very much.
Bracho,
it was a pleasure to be here.
Close the webinar. While that YouTube, so everyone can see this webinar. Take this.
Dale cámara. Dale. Está muy webcam. Dale clic. Y ahora sí puedo.
Thank you very much, Dilhana, for your patience from in moments when the online system went down. I think everything was very clear. Your concepts were very clear, and it reached everyone here. And I think that's the idea with the online systems. Well, thank you very much one more time. We will have all of this in a record, and we will broadcast these recordings on next Monday, and by YouTube. And well, this is the idea of keep going with this. Thank you very much, Dilhana. You were terrific. Thank you very much, Asalur, you too. And let's keep in touch. Thank you very much.